Anatomy of a health crisis, opioids, coming up next on Call the Doctor.
The region's premier medical information program, Call the Doctor.
The opioid crisis is one of the largest epidemics of addiction ever recorded in the United States. Each day, more than 200 people in the U.S. die after overdosing on opioids that include prescription pain relievers, heroin, and synthetic drugs such as fentanyl. In 2017, there were nearly 5,500 drug-related overdose deaths reported in Pennsylvania, according to the DEA. This number represents a 64% increase in overdose deaths from 2015 to 2017. The Centers for Disease Control and Prevention estimates that the economic burden of prescription opioid misuse alone costs this country $78.5 billion a year. The cause of this massive epidemic began in the late 1990s when the pharmaceutical companies reported to the medical communities that patients would not become addicted to prescription opioid pain relievers. As a result, opioids were prescribed at greater rates, with the tragic consequences that led to misuse of these medications and the realization that these drugs were highly addictive. Opioids, anatomy of a health crisis, now on Call the Doctor. Welcome to Call the Doctor here on WVIA. I'm Paula Giacomo. Our topic today, as you just heard, opioids addiction. Joining us for our discussion, Dr. Robert Friedman, Medical Director at Geisinger-Marworth Treatment Center, Dr. Donna Ige, a physician who treats addicted patients at her practice at Medicus Urgent Care in Dunmore, and Michael Arcangeletti, Director of Operations at Clearbrook Treatment Centers. Thank you all for joining us to talk about opioid addictions. Americans are at greater risk of dying from an opioid overdose than from a car crash. We have reached a national epidemic with opioid and heroin overdose. This is a crisis, and it's becoming more and more prevalent, even more so in the last decade. How did we get here? Did it all start with OxyContin?
Actually, Paula, the first opioid epidemic happened more than 100 years ago, and it was very similar to what's happening now. In the late 1800s, a drug called laudanum was distributed in the United States and promoted by physicians, and it was simply a morphine-based derivative, and it was very similar to what we're dealing with today. The overprescribing of that medication led to the same problems that we're having today with, prescription opioids.
Sure, they say it takes 5 days for someone to become addicted to opioids, and Pennsylvania is one of 5 states hardest hit by this epidemic. Dr. Ige, you work with patients trying to overcome opioid abuse, and one of the treatment options, the main treatment options, is medication-assisted treatment. What is that exactly?
Medication-assisted treatment is a process where we essentially give patients another opiate to satisfy their brain's desire for the illegal opiates or the strong doses of prescription opiates they're already taking. But the medication-assisted treatment medications use medications that are longer acting. So what that does for patients is it gives them a more steady state in their brain, which allows them to feel more normal, to function more normally, to carry out jobs, to be moms and children and brothers and sisters and employees and productive members of society.
And we're talking about Suboxone.
Correct. Suboxone is the trade name of a drug called buprenorphine, which is combined with naloxone, which is a blocker, which makes it safe and very difficult to overdose on. There are other trade names such as Bunavail or Zubsolv, but the basic medication in all of these is buprenorphine.
Now, Michael, you work at Clearbrook Treatment Centers, but you are in recovery. You were once a heroin addict, and you don't agree with medication-assisted treatment. You said it didn't work for you?
I wouldn't say I don't agree. I think if you're asking me personally what was effective for me, medication-assisted therapy didn't work, but I do believe it's an effective treatment modality. I'm not against it. I think under the proper circumstances, as in the treatment modality that's attached to the medication, it's a medication-assisted therapy, so the therapy is a crucial element to that being effective. So I'm not against it. I'm just for personally is what you asked.
Okay.
Yeah.
Well, some critics might say you're trading, one drug for another, but that's not true.
Medication-assisted treatment has a little bit broader definition than that, because you do have drugs that simulate or are similar to the drugs that are being abused, and that's the buprenorphine is what we call a partial agonist. It sort of acts like the illicit drug that someone might be taking. But you also have medication that's an antagonist. There'll be an opioid blocker, and that's part of MAT treatment as well. And that's called naltrexone, and the trade name of that is Vivitrol, and there's a once-a-month injection that will block it as well. So that's another kind of medication-assisted treatment. Methadone is another medication. That's an way of treating opiate use disorder. And then, of course, there's Narcan, which can be used in emergencies that will reverse overdoses. All of those are forms of medications that are used in treating the patient with opioid use disorder.
But Michael, you chose abstinence.
Yeah.
How did that was successful for you?
Correct. Yeah, and again, a day at a time, it continues to be. I think for myself, it was a learned experience of failure through other options to go after recovery. What ended up being effective to me was definitely long-term treatment, going through a process of being removed in a stable, supportive environment for a period of time where I got to get down into real, for myself personally, causes and conditions of why I was looking to a substance to feel good, and to take care of the underlying angst that was in me that drugs and alcohol worked for.
So getting to the heart of the issues.
Exactly.
Therapy, talk therapy.
Sure. Well, the heart of the problem is the problem in the heart. So you get to that, I think that's when you start to see people really come alive as to what it is. And medication-assisted therapy is a way to get to that part of the conversation. So it's utility you can't knock, but to get to some underlying causes in a person to answer that question of why are you using, what is it working for?
But Dr. Ije, can you go from being addicted to opioids to then being addicted to these medication-assisted drugs like Suboxone?
Suboxone, yes. Methadone, yes. They're both opiates. So essentially what happens with these medications is they cause changes in the neurotransmitters in your brain, and then your brain becomes dependent on those neurotransmitters to achieve the feeling that you want to achieve. So you don't feel good anymore without those medications because your brain's used to having those medications. But when we talk about MAT, medication-assisted treatment, the A is important. It's assisted. So as Michael pointed out, we're not just taking a pill of Suboxone every day, or just taking a pill of methadone every day, or just taking a shot of Vivitrol once a month. We're assisting that treatment with the other things we need to do, such as lifestyle changes and counseling to help us, get to where we need to be as far as understanding our disease and hopefully, in cases like Michael, achieving a full recovery.
And don't you believe that this type of medication is something to choose now, like until something better comes along, perhaps?
I think that these medications are the only evidence-based therapies that work for a good number of patients. It doesn't mean it'll work for all patients. Buprenorphine, Suboxone doesn't work for everyone, but it does help an awful lot of people. Methadone doesn't work for everyone, but it can help a good amount of people. And the blockers, like naltrexone, work as well. and they don't have any mood elevation, mood changes or significant mood changes that might interfere with people going about. Routinely, healthcare workers who have substance use disorders will take the route of seeking treatment with an opioid blocker so they can return to the workplace. If they have an opioid blocker, an injection once a month on board, there's less likelihood they're going to use opioids.
So if there's someone out there who is addicted to opioids or heroin, and they're interested in getting treatment, what's the first step they should do? You work in a treatment center, you work in a treatment center also. What advice do you have for them if they are looking to, come clean?
Come clean. I mean, the first step in this process is the admission factor of saying, like, I need help. Starting at a baseline of saying, what is currently going on in my life? I need to change. I want help. And that's a good starting point. The next step after that is to seek treatment, is to call one of the many facilities in this area or in general to reach out for and to start that process of getting the help you need. Because the big thing is you can't do it alone. This disease of addiction causes you to be alone.
Sure. And there's a hotline number you can call too, 1-800 hotline number, and talk it out.
And so many people are, are thrown into withdrawal. They overdose. They're brought into emergency rooms. They're given Narcan to resuscitate them, and that throws them into withdrawal. And they're sick. Their thinking isn't clear. Their brain has been hijacked by opioids, so there's not a clarity of thought. There's not good judgment there. But if they're sick like that, they need to be stabilized medically. It's an illness, and this is where certainly the medicated assisted treatment is so important to stabilize people, to get them at a point where their brain is starting to improve and their thinking's clearing. It's really hard to think clearly if you're in withdrawal and you're in physical pain and you're in emotional pain.
There's 125 million Americans suffering from chronic pain, and that's why Governor Wolf enacted certain protocols like warm handoff. When if you do go to the ER and you're overdosing, they'll introduce you to a counselor. Is that something beneficial?
The great thing about that is because it's an access point, is because like some people, like when they start to feel like they have a problem, they're not immediately picking up a phone. Usually it's a crisis that kind of motivates a person into treatment. Sadly enough, there's a lot of overdoses, and so when people overdose, they end up in an emergency room. And right now, the warm handoff process looks at an emergency room as an access point, looks at first responders, EMTs, police officers as an access point to the opiate-addicted individual to try to get them from that point into help.
Instead of just sending them on their way, introduce them to someone who could possibly get them on the road to recovery.
In our backyard, the Geisinger system is invested in this and working with, they have certified recovery coaches now in the emergency departments who can help patients find a place to go immediately. There's a block there, though. The patient has to want it.
Sure.
The patient has to want it almost as much as their family does.
Michael, is that how it was for you? I mean, did you come to a point where you were like, I have to get sober?
I mean, I knew the way I was living. I knew the pain and the depression and anxiety that I was going through. I wanted it to stop. I just didn't know how. And so I started with a desire for change. And like fanning that desire is what people in positions to help do. You know what I mean? But it's that courage it takes to then start taking that next step to saying, like, everything I've decided to this point in my life has got me here. I have to adopt another way of thinking to get out of it. You know, and so there's a surrender aspect that comes along with this whole process of change.
And changing your thinking. Well, should the focus of treatment be more comprehensive, because so many addicts suffer from depression, anxiety? You know, is there a way to help treat the underlying issues rather than just giving out more medication?
By engaging patients in treatment and establishing a relationship with a qualified healthcare provider who's sympathetic and understanding and can help direct them to getting the sort of care we need. We see a tremendous amount of relapse. We know, for instance, that there's studies that say that 50% of the women who are entering treatment for opioid use disorder who've had 5 or more treatments have been sexually molested before the age of 12. This is a childhood trauma is a really big factor in fueling relapses. You know, so certainly different depression, anxiety, bipolar disease, but it's hard to tease out what is the substance use, what is the withdrawal, and what's the underlying, you know, mental health issue. So it takes some time, and using the medicated assisted treatment gives us a chance where the patient can be stabilized and we can begin that process. Now, some patients may wind up on MAT for long periods of time. It's a chronic illness, you know, and that can happen, but other patients can come off as well.
And stigma is a big issue too, which is why some people, you know, don't immediately come forward. Was that a problem for you in seeking help?
Oh, at some levels, absolutely. You know what I mean? And I think a major aspect of this whole process is environment, like an ecological perspective of saying, like, how did we get here too? I think we have to look at those type of factors too, like specifically stigma and stuff like that, of being kind of looked down upon, or kind of like, not like necessarily shunned, but just don't do that in front of me, you know what I mean? Or, you know, like placing people to the side in a way of like not acknowledging the degree to which the severity of this problem is there. And then judging people because of it is a result.
Okay. I want to get to an email question. This person wrote in, I'm scheduled for back surgery. What are the alternatives to opioid-based medications to manage pain? This is James from Wilkes-Barre. Dr. Ije?
No one has ever died from pain. So I think one of the biggest things people have to do in a self-assessment of this process and trying to prevent this problem from propagating is to say no to pain medication.
No thanks.
So certainly there's a level that everyone has that they say, you know, this is enough, but physical therapy is an option. That's going to be weeks or months even later after surgery. There's nonsteroidal anti-inflammatory drugs, the Motrin class, that help a lot of people with pain. There are lesser opiates like Ultram or Tramadol, which are not so addicting. Neuromuscular blockers like gabapentin, Lyrica, those kinds of medications. But depending on the circumstances, you can go out of back surgery and not need anything for pain at all because the surgery's fixing the problem. But it doesn't matter whether it's back surgery or a dental extraction. It starts with your philosophy as the patient to say, I'm just going to really try to tough this out rather than start down this pathway.
Aren't doctors shortening the amount of time you're on the medication?
Yes, and there's a scientific basis to that. You know, first of all, I believe in the acute postoperative period, patients should be given pain medications. You know, it's
but
how
for
long,
a limited amount of days.
Exactly, and particularly if if your family has alcoholism or addiction in it, you may have the same propensity to developing it quickly. As you said, we know that, you know, these medications are great, you know, for short term, but if long term, short-acting opioids, OxyContin, doesn't work. In fact, studies show it increased pain when patients were taking it for months at a time. So the thing that was prescribed to take the pain away was actually increasing the pain.
Wow.
And of course, the physicians weren't told this when the medication was widely promoted by pharmaceutical sales forces. And there are many different opioids that were promoted this way.
And when it comes to heroin overdosing, the problem today is you're not getting heroin anymore. It's fentanyl, a synthetic drug made in China that can kill instantly. So,
in fact, most deaths today are with, people think they're taking heroin, but instead they're taking fentanyl. The reality is, and this is a shocking statistic, less people die of heroin addiction than die from prescription opioid usage. Those medications prescribed by their physicians.
So more people are dying from opioid prescriptions than from heroin abuse.
Statistically, yes. It's a few thousand difference, but the number is lower with heroin than with prescription opioids.
There's another problem, Paula, that we're seeing, and that pills are counterfeited. So you can think that the pill that someone sells you, because you ran out of your Percocet early, is Percocet, but you can actually buy a pill press on eBay and fill it with something like fentanyl, which is much cheaper, and people don't know what they're getting. And
if you're buying it on the street.
Correct. You think you're buying Percocet and you're buying fentanyl.
Yeah, they're illicit, sedatives, benzos, which are medications like Xanax and Klonopin that people are buying illicitly, and those are either are fentanyl or being cut with fentanyl, which is even more shocking.
So the treatments that you offer in your facilities, what do they entail? Michael?
Oh, at Clearbrook, the treatments that we offer range from, we do a lot of cognitive behavioral therapy with our patients. We utilize 12-step philosophy with our patients. We as well employ like rational emotive therapy, a lot
Are
of
these
motivational.
all outpatient services?
No, this is inpatient. So it's an inpatient treatment facility.
Okay. And how long would you have to stay?
28 days is
28
a typical
days.
stay.
Okay. Does insurance cover it?
Yes.
Okay.
Yes. Yes.
And does someone have to go willingly? Can someone force them to say, hey, take my kid?
There are only 3
Yes.
states in the
Yes,
United
you have to go willingly.
There are
Well,
only-
no, I mean that exactly what you just said happens. A lot of them just take them. It's your problem.
There are only 3 states in the United States where people can be committed for substance use disorder. But that's a debate that's developing on whether, when you've had people who've had 10 treatments, there's a point, do they need to be evaluated? Do they really have a say at that point, or can they be committed when they keep going in and out of treatment?
So you're saying in Pennsylvania you can commit someone?
No, you cannot. There are only 3
They have
states
to go willingly.
in the United States.
Okay.
All right. What we do at Geisinger Marworth is that we stabilize patients on buprenorphine, and we will detoxify them off it and offer them choices. We offer them opioid blockers as well, and do a transition from the buprenorphine, from the opioid to an opioid blocker. We also take patients in treatment who are on Suboxone maintenance programs, and we will keep them on that medication at their dose and take them off of the other substances they're using, like amphetamines and benzos and alcohol. The combinations of sedatives and buprenorphine can be deadly. And so we can do that and then turn them over to one of our MAT clinics. Geisinger has 4 medicated assisted treatment clinics, one in Williamsport, Bloomsburg, Wilkes-Barre, and one's opening in April in Scranton. So we certainly have the resources here, and we have enough beds in the Wyoming Valley to treat people. I don't have the same experience with the insurance companies that Michael does. I find them a little more difficult to deal with, but we fight for our patients to get that state covered. I do a lot of doctor-to-doctor phone calls, and they're not always very pretty, but we fight to get the patients covered.
Yeah, and we did have the 1-800 number on the screen, so if anyone needs treatment, please call that number on your screen. This has been an epidemic that has just been growing by leaps and bounds. In Lackawanna County alone, there were 9 deaths in 1 week, overdose deaths. So this is definitely hitting home
And in Luzerne
hard.
County, the death rate went up this year, even in 2017, and it looks like it's on the rise for 2018 as well.
Okay. Well, thank you for joining us, and thank you, Michael, for telling your story. We appreciate all the information that you brought forward. And again, if you're having any troubles with opioid or heroin overdose abuse, please call the 1-800 number on your screen. Once again, I'd like to thank our panelists for participating in our discussion on opioid addiction. For more information and to continue the conversation, visit WVIA.org/CTD. I'm Paula Giacomo for Call the Doctor. Thank you for watching.